Hello, my name is Jeff Hill, and I am a cardiac sonographer from the University of Massachusetts Medical Center, Worcester, Massachusetts. Today we are going to talk about the assessment of diastolic function, which will include the basic physiology, review of the literature, technical tips, and case studies. I would also like to take the time to discuss in detail the validation studies for the Doppler tissue imaging and the estimation of filling pressures. Upon completion of this presentation, the participants should be able to explain the various stages of diastolic dysfunction, identify the Doppler waveforms that are used to evaluate diastolic function, discuss the technical and physiological factors that influence diastolic filling, report diastolic values and Doppler values that may indicate normal and abnormal diastolic function, and lastly, explain why a comprehensive approach with integration of several diastolic and structural parameters is necessary to accurately characterize diastolic function. So why assess diastolic function? This information was modified from Dr. Navee's report from the reviews of cardiovascular medicine, demonstrating changes in treatment that may occur in patients with mild, moderately elevated, and highly elevated filling pressures and abnormal diastolic function. As you can see, in what we will refer to as stage 1 or mild diastolic function, a symptomatic patient with exercise intolerance and or unexplained hypertension with abnormal relaxation but no evidence of elevated left atrial pressure may require medications to control heart rate, regression of hypertrophy, and afterload reduction. However, both stage 2 pseudonormalization and stage 3 restricted filling may include additional medications such as diuretics, nitrates, and digoxin, all of which help with control of preload, afterload, improved survival benefit, and left ventricular remodeling. Given that medical therapy may be tailored in such a way, it is obviously imperative for the sonographer to correctly obtain cardiac measurements to determine the extent of diastolic function. The ASEUII Diastolic Function Guidelines. The American Society of Echocardiography's Diastolic Function Writing Group recently published guidelines and standards for the evaluation of diastolic function. This document was published in both the Journal of the American Society of Echo and the European Association of Echocardiography. I will say this is a landmark document that provides information on diastolic function that includes normal values for both standard and refined Doppler values, such as Doppler tissue imaging. Also, as you can see to the right, in the panel to the right, there is important information reported for the assessment of filling pressures in special populations, such as atrial fibrillation, tachycardia, mitral stenosis, and mitral regurgitation. Let's now begin with the echocardiographic variables used to assess diastolic function. Here is an example of pulsed wave Doppler with the sample volume placed at the leaflet tips. There are three components that are measured: the mitral E wave, the E wave deceleration time, and the A wave. The transmitral E wave velocity reflects the pressure gradient between the LA and LV in early diastole. The E wave deceleration time represents the rate at which the LV and LA pressure equalize during early diastole or early diastolic filling. The transmitral A wave velocity reflects the LA contribution to LV filling in late diastole after atrial contraction, which is noted as the P wave on the ECG. Now there's a fourth measurement, which is the mitral A wave duration. This measurement is obtained by placing the sample volume or repositioning the sample volume towards the annulus, and the filters decreased. What this does is it improves the demarcation lines of the cessation, the onset of the A wave, and then the cessation of the A wave down to the baseline, which will result in improved accuracy of the A wave duration. Now, importantly, I want to make note that the E to A ratio decreases with normal aging, as the A wave increases along with the deceleration time increase. Pulmonary vein Doppler characteristics. Here is an example of pulse wave Doppler with the sample volume placed at least a half a centimeter into the right upper pulmonary vein. There are three waveforms that are seen. The first waveform is the systolic waveform of the S wave. The second waveform is the diastolic waveform of the D wave. And the third waveform is the atrial reversal waveform, or the AR reversal waveform. The S wave velocity is determined by the filling of the LA during ventricular systole. The D wave velocity reflects the passive conduit function of the LA during ventricular filling, which correlates with the mitral E wave. The atrial reversal, or AR velocity, represents the retrograde flow from the LA into the pulmonary veins during end ventricular diastole. Now, the pulmonary venous velocities are influenced by age, and young subjects usually have a prominent D wave velocity. What this reflects is a tall mitral E wave, both of which is a product of diastolic suction, not elevated left atrial pressure. Now, with increasing age, however, the SD ratio increases, and in normal subjects, the atrial reversal velocity can increase with age, but usually does not exceed 35 centimeters per second at any given age. Higher values suggest increased LV and diastolic pressure greater than 15 millimeters of mercury. In addition, the pulmonary vein A wave duration should not be greater than the mitral A wave duration normally. If the pulmonary vein A wave duration exceeds the mitral A wave duration, this also is an indication that the LV and diastolic pressure is elevated greater than 15 millimeters of mercury. Doppler tissue imaging, or DTI, characteristics. So here is an example of pulse wave Doppler tissue imaging, or DTI, with the sample volume placed at the septal annulus. There are three major waveforms displayed above and below the baseline. The first waveform is the systolic waveform of the S prime velocity, not to be confused with the pulmonary vein S wave. Therefore, we have to give it a slightly different name. That also applies to the early diastolic, or E prime velocity, and to the late diastolic A prime velocity. Now, the E prime velocity reflects the rate of ventricular myocardial lengthening during early diastole, at which the period in time where the heart recoils back through diastole. Now, to clarify further, the higher the E prime velocity, the faster the relaxation, or the better the relaxation. Now, conversely, the lower the E prime velocity, the slower the relaxation. The A prime velocity reflects the rate of ventricular lengthening during late diastole, during atrial systole, which corresponds to the P wave on the ECG. The E prime velocity is usually greater than 10 to 12 centimeters per second normally. We will discuss in great detail these velocities throughout the rest of this presentation. The E to E prime ratio for estimation of PCWP, or pulmonary capillary wedge pressure. The E to E prime ratio is the peak mitral E wave divided by the tissue Doppler E wave. This ratio has been validated as a reliable index for the estimation of mean LV diastolic pressure, mean left atrial pressure, LV pressure, all of which is a surrogate of pulmonary capillary wedge pressure. This ratio, its validation, technical tips and caveats will be discussed extensively and in detail throughout the rest of this presentation. Next is color M mode for the assessment of LV relaxation and pressure. Now, color M mode flow propagation, or VP, or velocity propagation, represents the velocity of blood flow from the mitral leaflets into the LV cavity towards the apex during early diastole. Acquisition is performed at the apical four-chamber view, and the MO cursor is placed through the center of the LV and flow blood column. Now, as you can see in this example to the left, the LV is shifted slightly to the right to improve the alignment into the LV, and you see how nicely the color lines up into the LV cavity. The color flow baseline is then shifted upward to lower the Nyquist limit so that the central highest velocity jet within the color MO display in early diastole is blue or orange to blue. The slope of the first aliasing velocity during early filling is measured from the mitral valve plane, which is identified on the M mode, where the M mode demonstrates the mitral valve opening, to about 4 centimeters distally into the LV cavity, as recommended by Garcia and colleagues. Now, a VP of 50 centimeters per second is considered normal. In addition, the transmitral E-wave velocity can be combined with the velocity propagation and as a ratio to predict LV filling pressures. An E over VP of 2.5 predicts a pulmonary capillary wedge pressure of 50 millimeters of mercury with reasonable accuracy. Let's now talk about LA volumes and diastolic dysfunction. LA volumes are an important biomarker in disease. So as the LA volume and size increases, this reflects chronic pressure volume overload over time. An LV volume index greater than or equal to 34 mLs per meter squared is an independent predictor of death, heart failure, atrial fibrillation, and stroke. Now, these measurements are obtained from the apical 4 and 2 chamber view and are easily measured. Of note, the LA size is traditionally measured by linear measurements from both the parasternal long axis and the apical 4 chamber views. However, I will say in some instances, LA size is significantly underestimated if the parasternal measurements are used only. Therefore, we have incorporated LA volumes recently into our laboratory to better assess LA volume and size. Now, LA volumes, if corrected for body surface area, may better represent LA size and dilation. And importantly, the ASEUII has a document, which is the Chamber Quantification Guidelines that were reported back in 2005. These guidelines provide reference ranges for both men and women, and this document is available on the ASEUII website. Effects of the Valsalva maneuver on transmitral filling. The Valsalva maneuver can be applied to determine if the filling pressures are elevated by reducing preload and unmasking the underlying relaxation abnormalities. This technique is performed by forceful expiration against the closed nose and mouth. LV preload is reduced during the strain phase, and changes in mitral inflow are observed to distinguish normal from pseudonormal or reversible restrictive filling. A decrease of 20 centimeters per second in the peak mitral E-wave velocity is usually considered an adequate effort in patients without restrictive filling. However, I will say this technique is difficult to perform for both the sonographer and the patient, as the images may be lost or the sample volume moves away from the mitral leaflet tips. The idea would be to practice, so have the patient begin to bear down, reposition the sample volume to see what the image looks like, and then activate pulse wave Doppler. Also, it's important to note that Valsalva maneuver cannot be applied in critically ill patients who are intubated, of which I think estimation of filling pressures could be extremely helpful in these patients. Let's now shift gears to the classification of diastolic dysfunction. This information was obtained and modified from Redfield et al. From JAMA 2003, which dichotomizes both normal and abnormal diastolic function. This schematic includes the mitral E to A ratio, deceleration time, Valsalva maneuver, DTI, and pulmonary vein Doppler. Now, as you can see, under the normal diastolic function classification, let's then compare the differences as we move from mild to moderate to severe diastolic dysfunction. Now, stage 1, or what is considered impaired relaxation, you see that the mitral E-wave deceleration time increases due to prolonged LV relaxation. The mitral A-wave increases due to prolonged filling and loading of the left atrium. This filling pattern indicates, in most instances, normal LA pressure, or a pressure less than 15 millimeters of mercury. However, transient elevations in LV and diastolic pressure may occur, which I will share with you in one of my cases that are towards the end of the presentation. Now, stage 2 diastolic function, or pseudonormal, you see the mitral E wave, E deceleration time, and A wave, and the E to A ratio appear normal. This occurs because the LA pressure begins to rise gradually as the filling pattern transitions from an impaired relaxation to a normal-looking filling pattern. The mitral E wave increases. We shorten the E wave deceleration time with left atrial filling. Valsalva maneuver is very helpful in differentiating normal from pseudonormal filling by reducing the mitral E wave and increasing the E wave deceleration time. This maneuver unmasks the underlying relaxation abnormality, and this filling pattern indicates elevated left atrial pressure and LV end diastolic pressure. Now we have more severe diastolic dysfunction, which is stage 3, or reversible restrictive filling, meaning the Valsalva reduces the mitral E wave by decreasing preload. This filling pattern indicates elevated LA pressure and LV end diastolic pressure. Also, you see that the pressures equalize rapidly between the atrium and the ventricle. Therefore, the deceleration time is very fast. Now, stage 4, which is probably the worst that it gets, is the diastolic dysfunction called fixed restrictive or irreversible restrictive filling. Filling pressures are so elevated in these patients that the Valsalva maneuver has little or no effect on the mitral E wave. This filling pattern indicates highly elevated left atrial pressure and LV end diastolic pressure. Now, although the prior slide conveniently categorizes diastolic function, we have noted that each diastolic measurement, range, and partition values do not fit perfectly in the scheme of things. Preliminary data from our laboratory reported the prevalence of unclassifiable diastolic dysfunction using current criteria, or what we refer to as real-world diastology assessment. The study was undertaken to determine the percent of patients with measurable diastolic function variables and to determine the percent of patients with concordant data, meaning that if we use the schematic from the last slide, how often does each one of those classification from each variable fit the scheme of things in a patient in regards to their degree of diastolic dysfunction. So echo data on 100 consecutive patients were obtained in patients located in the ICU, CCU, outpatients. It didn't matter where these patients came from, and all the patients were in normal sinus rhythm. Now, the echo measurements included the transmitral E wave, the deceleration time, the A wave, the Doppler tissue E prime, and the ED prime ratio. In addition, the pulmonary vein S to D ratio, and A wave duration. Now, diastolic function, as I mentioned, was classified based on the scheme of Redfield et al. From JAMA 2003, which was on the prior slide. Now, interesting, our results show that the E to A ratio is measurable in only 71% of the population. Now, with the most common reasons being the fusion of the mitral E and A wave, which we would expect in tachycardia, and or absence of the apical window. Now, contrary to previous reports of feasibility of pulmonary vein flow in over 80% in a control population, feasibility of the pulmonary vein flow in a non-randomized population, as we are discussing here now, was significantly lower for the S&D ratio at 56% and the A-wave duration just 25%. That being one of the most difficult parameters to measure for the assessment of diastolic function. Now, of patients with measurable data, only 55% of the patients had 3 or more concordant variables. And strikingly, most of the concordance was seen among individuals with normal diastolic function. So the take-home from this study was that 1/3 of patients could not be classified, and only about a half of the patients with measurable data had greater than or equal to 3 concordant measurements. So these data suggest the need for a weighted classification scheme, which will incorporate LA structure, LV structure, and importantly, PA pressure. Now keep in mind, in most cases, if your PA pressure is not elevated, then it's very difficult to say that you have elevated mean left atrial pressure. They typically go hand in hand. And work published by Bouchard et al. Back in 2007, which is also in the diastolic function guidelines, demonstrate that this is an important measure to include when you're assessing diastolic function. Now, here's where it gets exciting, the DTI E' velocity validation. As I mentioned earlier, I want to go into great detail discussing the validation or the genesis of the DTI E' velocity or the tissue Doppler velocities. And I will say in 1997 was when the rubber hit the road for diastology. In addition to Dr. O and colleagues' seminal report on diastolic function for the conventional parameters measured, and Dr. Appleton and colleagues' intriguing work on pulmonary vein physiology and technical tips, which we will address later in the talk, validation of the E' velocity and E to E' ratio for the assessment of relaxation and filling pressures were reported. One of the first studies to validate the DTI E' velocity in tau, or time constant of isovolumic relaxation, was from Oki and colleagues. A sample volume was placed in the posterior wall, and the myocardial velocities were compared to tau in 50 subjects. Abnormal tau or relaxation was defined as greater than 50 milliseconds. This is typically the standard that's used when evaluating against tau. 50 milliseconds is typically the cutoff value that's used and will be provided throughout the additional validation studies. The image to the bottom right, which I have here, was adapted and modified from Dr. Oki and colleagues. What this demonstrated that there was a significant negative correlation with the E' velocity in tau. Now, as I mentioned earlier, the lower the E' velocity, the slower the relaxation, as shown in the linear regression equation to the right. Now, shortly thereafter, Son and colleagues' work on loading conditions and DTI validation with tau was published. In this study, mitral linear DTI was measured in 90 patients that included normals and in patients with various disease stages and filling pressures and alterations of filling pressures by saline loading or nitroglycerin. In addition, 38 consecutive patients undergoing cardiac catheterization were studied. Again, tau greater than 50 milliseconds in this study was considered abnormal. Now, to the right, in the linear regression equation, you can see that there was a modest but significant negative correlation between the DTI E' velocity and tau. And again, to remind you, the longer the tau, the prolongation of tau, the lower the E' velocity, or the slower the relaxation. Now, to the left, as you can see, DTI helped to dichotomize differences between various transmitral filling patterns. For example, in the normal mitral inflow, you see that the E' velocity is well preserved. However, if you just look to the right there, in the pseudo-normal example, the E' velocity is significantly reduced with further reduction in both the E' and A' wave with progressive disease. Now, the take-home from this study was, despite the alterations in loading conditions, such as the administration of saline and or nitroglycerin, the DTI E' velocity did not change significantly. In addition, the DTI E' velocity obtained from the septal annulus less than 8.5 centimeters per second could distinguish between normal and abnormal tau. Now, for the first time, we have a relatively preload independent echocardiographic method to measure both myocardial relaxation with reasonable accuracy. Now, to extend the work of Dr. Son, Dr. Naga and colleagues validated not only the DTI E' velocity, but for the first time a ratio for the assessment of filling pressures. In this study, 125 subjects were included that had patients that were normal, that had various disease states, such as heart failure symptoms and abnormal filling pressures, of which 60 of these patients had invasive measurement of pulmonary capillary wedge pressure, or PCWP, simultaneously when the DTI was obtained. The DTI in this study was obtained from the lateral annulus. Now, the transmitral E wave and DTI E wave were used as a ratio to estimate the filling pressures. This is where the E to E prime ratio evolved from. Now, as you can see here to the left, similar to Dr. San's work, the DTI helped to differentiate between various transmitral filling patterns. And then specifically, you can see in the normal example, again, the E prime is very tall, indicating there's normal relaxation and normal tau. But if you look over at the pseudo-normal, you see that the E prime velocity is significantly reduced. In this example, you can see where if we have similar mitral inflow patterns, we now can unmask that by using tissue Doppler to show that indeed there is an underlying relaxation abnormality in the pseudo-normal patient. Now, to the right, in the linear regression equation, you can see there was an excellent correlation between invasively measured pulmonary capillary wedge pressure and the E to E prime ratio. And if you draw a line, as I did, across from the y-axis and vertical from the x-axis, you see that the E to E prime ratio of 15 meets the pressure of 15 millimeters of mercury. Hence, greater than 15 is greater than 15, or 15. Now, suffice to say, if the E to E prime ratio was greater than 15, you were able to distinguish between patients with pseudonormal filling and elevated wedge pressure as seen in the patients with the open circles. So all the patients with the open circles are patients with pseudonormal filling. Now, the higher the ratio, the higher the wedge pressure. And similar to Dr. San's work, they reported that the E prime velocity behaves as a preload-independent or relatively preload-independent index of LV relaxation. And importantly, mitral E wave velocity, when corrected for the influence of the relaxation, as you can see in that example, we can correct for the pseudo-normalization of the elevated filling pressure by use of the E to E prime ratio relates well to the mean pulmonary capillary wedge pressure and can be used to estimate LV filling pressures with great accuracy. Well, the work of Doppler tissue imaging was extended, and its validation was extended, and by the turn of the century, in the year 2000, work by Ullman and colleagues for the assessment of DTI and filling pressures took a slightly different approach, including both the septal and lateral annulus, and normal versus abnormal ejection fraction. Now, of note, this is the largest study to validate the E prime velocity. This study included 100 consecutive patients. The mean LV diastolic pressure was measured, and an elevated LV filling pressure was defined as mean LV diastolic pressure greater than 12 millimeters of mercury. So a little bit lower than what was reported in Dr. Naga's work. As you can see in the regression equation to the right, similar to Dr. Naga and Dr. San's report, their results showed a correlation between tau and E prime velocities. The open circles indicate patients with an EF less than 50%. The closed circles indicate patients with an EF greater than 50%. The correlation was worse actually in patients with normal versus abnormal EF. In the above panel, the sensitivity and specificity improved slightly with the use of the septal E prime velocity for the prediction of mean LV diastolic pressure. The bottom panel demonstrates the septal E to E prime ratio having better prediction for elevated filling pressures than the other standard Doppler indices used for the assessment of LV diastolic function, such as the E to A ratio or the deceleration time, Valsalva maneuver, and even the pulmonary vein wave velocities. Of note, the E to E prime ratio was probably the single best parameter for predicting mean LV diastolic pressure was importantly obtained most readily. Now, as a continuation from the previous slide in Dr. Ullman's work, as you see here on the y-axis is the LV diastolic pressure, and on the x-axis are the cutoff values and ranges for the E to E prime ratio. E to E prime ratios less than 8 accurately predicted mean LV diastolic pressure, and E to E prime ratios greater than 15 identified increased mean LV diastolic pressure. But if you look in the middle there, between the 8 and the 15, if you have a range between 8 and 15, you see I put a question mark there because In this group of patients with an EDE prime ratio between 8 and 15 required a very detailed, comprehensive assessment of not only Doppler but structural assessment as well, and that's extremely important. So in addition to looking at the ED prime ratio, if you do have one from 8 to 15, it is important to include PA pressure as that being a surrogate or an estimation or a possibility that LA pressure may be elevated if the PA pressure is elevated. Also, is there left atrial enlargement, LA enlargement, that being an indication that there could be chronic pressure overload and that the LA pressure may be elevated. So please use a stepwise approach in patients that have a ratio between 8 and 15. I just want to show you an example of normal and abnormal DTI waveforms. As you can see here, there are two examples of that. They are similar age, and as you can see here to the left is a normal 42-year-old patient with a normal EF. Normal DTI E prime, A prime, and ED prime ratio. Also note that the DTI systolic or S prime waveform is normal near 10 centimeters per second. Now, just over to the right here is a 48-year-old with an EF of 25% and wall motion abnormalities. You can appreciate a significant reduction in the E prime, A prime, and E to E A prime ratio. Also note in this example the significant reduction in the DTI S prime waveform. Now, when measuring the DTI E prime velocity, do not mistake the isovolumic relaxation time or the IVRT waveform for the E prime waveform. This can happen more often than not as the myocardial function deteriorates, relaxation worsens, and what you'll see is that the isovolumic relaxation waveform can be higher than the E prime waveform. But as you see here, the first waveform after the crossover of the zero Doppler baseline, so as the S prime waveform reaches the zero Doppler baseline and ends systole, that is the beginning of diastole. So therefore, that first waveform that occurs below the baseline is the isovolumic relaxation waveform in almost every case. Now, this example is of a patient with LVH and mild diastolic dysfunction. As you can see, the first waveform displayed below the baseline after the cessation of the S prime waveform is small with little or no spectral display. This is what we would refer to as a prominent isovolumic relaxation waveform, and if you look just to the right, that is where the peak E prime waveform is located. Now, in addition to that, of note, if you can see here that at the end of the S prime waveform, there's prolongation of the IRT, and this is observed from the cessation of the S prime waveform to the onset of the E prime waveform. And the worse of the relaxation, that longer that period is. That's very similar to the isovolumic relaxation period that would be measured by standard pulse wave or continuous wave Doppler. Now, here are two examples of the full Monty assessment of diastolic function in a normal and abnormal patient. You see to the left is the normal and to the right is the abnormal. Now, which one or a couple of these tracings are not like the other? Now, if you look at panel A, you see that the E to A ratios are about the same, and the deceleration time is near the same also. So really, there's nothing different that we can tell whether one has filling pressures and the other one has elevated filling pressures, and one has normal filling pressures. But if you look just to the right in panel B in both the normal and abnormal, and you see in the normal example, as we reduce preload, both the E and A proportionally decrease. However, there is some increase in the deceleration time with little change in the A wave. But off to the right, you see that E wave comes down significantly, inverts the filling pressure, or inverts the waveform, the E and A ratio. The deceleration time increases and the A wave increases. That A wave increase is most likely, I think, a product of increased deceleration time with more atrial filling, hence more atrial contraction and more loading into the ventricle to end diastole. Now, if we look down at panel C, the A wave durations are virtually the same, so panel A and C really have no difference at all. But if you look to the right, the pulmonary veins tell a nice story here. We see that the S and D wave in the normal example ratio is about 1 or just above 1, and the atrial reversal velocity and duration are normal for the most part. But if you look off to the right, we see that there's a blunted systolic waveform, of which could be a product of atrial relaxation or some atrial dysfunction included. And also the D wave is increased, so the S to D ratio is inverted, and the D wave is more prominent. The D wave probably representing more consistent with elevated left atrial pressure, as that reflects the E wave. And then if you see below the baseline, the A wave duration is prolonged, and the atrial reversal velocity is up near slightly increased, or just above normal. And then off to the left here, you can see that in panel E, the tissue Doppler tells a really nice story. And you see at the lateral annulus in this normal example, the E prime and E to A prime velocities are well preserved. And if you look at the abnormal example, and also the S prime, but if you look at the E wave in panel E and the A wave and the S prime, they are all significantly reduced with a reduction in the E prime velocity. And lastly, the color M mode, you see that see how the color M mode propagation in F in the normal example is upright. So the steeper that is, or the more upright that is, the more normal the diastolic function is, or the relaxation is. But look off to the right, you see that there's a very significant slope to the M mode, indicating severe relaxation abnormalities. So now let's talk about the factors that may influence the Doppler tracings. First is the sample volume positioning. Second, the Doppler gain. Third, annular restriction, either due to mitral annular calcification or MAC, or mitral valve replacement or repair. Respiration, regional dysfunction, and importantly, color DTI. So I also want to talk about the sample volume positioning and the effects it has on the pulmonary vein Doppler tracings. And as you can see here, there are two examples. You see to the left is the poor tracing, obviously. You see that this tracing was obtained during normal respiration. And you see that even though the sample volume is placed within the pulmonary vein, I really have to attribute the poor tracing from respiration. And you see that the image quality is poor. The peaks are not well defined, and probably would not measure this pulmonary vein Doppler profile. However, if you look to the right, the pulmonary vein tracing was obtained during apnea in the same patient. And you see the peak waveforms are clearly defined, some of the best tracing that I've seen in quite some time in the same patient, just by having the patient hold their breath or during inexpiratory apnea. And you can see that these peak waveforms can be easily measured. Next is color M mode cursor positioning. Now this is absolutely critical. Not only cursor positioning, but the phase of respiration can significantly change or alter the color M mode propagation velocities. Now in the left panel, the cursor was positioned slightly to the right. If you see what that yellow arrow is, it's not directly across the LV as it should be, and it was obtained during normal respiration. Because the cursor is not positioned directly across the LV inflow, the propagation slope, or the VP, is inaccurate and difficult to measure. Now, if you look over to the right panel, where there's proper positioning of the color M mode across the LV cavity into the LV cavity, you see that with proper alignment obtained during apnea in the same patient, the VP is clearly defined and can be easily measured. Sample volume placement highly influences the Doppler tracings. The DTI tracings to the left demonstrate incorrect sample volume placement slightly below the annulus towards the LV cavity during normal respiration. The DTI waveforms are faint and difficult to measure, as you can see there. Now, if you reposition the sample volume towards the annulus during apnea, you see there is a striking difference between these two waveforms. And in the panel to the right, the sample volume was placed during N-expiratory apnea. Now, the DTI recordings are uniform, they're consistent, they have minimal spectral broadening, and obviously they're easy to measure. Let's now talk about the effects of gain on DTI waveforms in the same patient. You see in this example at the top, the gain is adjusted too low, and you see that although we have a waveform there, the E prime velocity and the other waveforms are faint and difficult to measure. Now, the E prime velocity in this example is 8 centimeters per second. Now, look what happens when you increase the gain or you overgain the image. You then, in the same example, we have waveforms that appear coarse and with spectral broadening. And what you see here is that the E prime velocity is now 16. We now have a 100% increase in the E prime velocity just by adjusting the gain. Suffice to say that during the validation studies that knowing Dr. Naga and Son's work, that in Dr. Ullman's work, that the tissue Doppler, like all Doppler variables, were fine-tuned to really accentuate the Doppler signal. So what you see here with gain that is properly minimized, it allows for clear signals with minimal background noise, and you can see that the E prime velocity equals 12 centimeters per second, which probably really represents the true myocardial relaxation. Suffice to say, mitral annular calcification is quite common in the older population and in patients with advanced cardiac disease. However, to my knowledge, the literature is lacking a validation study demonstrating the effects of MAC on the E-to-E prime ratio. I will say that ASEUII and colleagues back in 2001 reported that mitral valve annular restriction due to mitral annular calcification, or MAC, may influence the E-to-E prime ratio, which results in the decrease in motion of the annulus, which will increase that ratio, but it doesn't necessarily reflect that there's elevated filling pressures. As you can see in this example, in a patient with mild to moderate posterior mitral annular calcification, the sample volume is properly placed at the annulus or site of the MAC, and the E prime velocity measures just 5 centimeters per second. Now, if you shift the sample volume or reposition it just below the annulus, you see that the E prime velocity measures 9 centimeters per second. So which velocity do you use? I will say I would use caution when estimating filling pressures in the presence of MAC, as the E-to-E prime ratio has not been well validated in these patients. Now, the same applies to valve prosthesis. This image was modified from work published from our laboratory in Cardiac Ultrasound Today in 2008, demonstrating similar changes that occur in the angular velocities in a patient with a mechanical mitral valve compared to patients with MAC. So you see here the DTI images in panel A and B were obtained at the annular level, and the average E prime velocity was 4 centimeters per second. But look just below, the sample volume was then repositioned towards the LV at both the septal and lateral annulus, just below the MVR, and you can see the striking differences in the peak E prime velocities. Now, keep in mind, the validation studies for the E prime velocity and E-to-E prime ratio did not report the severity of MAC and was not validated in patients with mitral valve prosthesis. So, how do wall motion abnormalities influence the E-to-E prime ratio? Revis Gotts and colleagues evaluated 104 patients, half of which had an EF greater than 50%. These patients underwent right-sided cardiac catheterization in the catheterization laboratory or in the ICU. They concluded that because of the heterogeneity and regional function that's present in reduced EF in the patients with regional wall motion abnormalities, if you average both the septal and lateral E prime velocity, this may best represent pulmonary capillary wedge pressure. Now, in addition, they found that in patients with normal EF, the E-to-E prime ratio using the lateral E prime had the best correlation with wedge pressure. Here is an example of a patient with severe left atrial enlargement, septal akinesis with basolateral normal or hyperkinesis. This is a continuation from the previous slide, and as you can see in the top left panel, there is a normal appearing mitral inflow. Now, because of the normal appearing transmitral inflow in the presence of severe LV dysfunction and LA enlargement, Valsalva was performed in the top right panel, demonstrating a significant reduction in the transmitral E-wave velocity, significant increase in the E-wave deceleration time, and just a slight increase in the transmitral A-wave velocity. These findings support elevated filling pressures. The bottom left panel shows the DTI obtained from the septal annulus in an area of akinesis. The velocities are markedly reduced, and the E to E prime ratio is 19, also supporting elevated filling pressures. However, DTI obtained in the bottom right panel in the region where there's normal kinesis shows a completely opposite spectral display with a normal E prime velocity. The E to E prime ratio is just 7, indicating normal filling pressures. Therefore, in patients with regional long motion abnormalities, especially at the base of the LV, an average of both septal and lateral E prime velocities may improve interpretation of diastolic function and filling pressures. What about the effects of respiration on the DTI waveforms? Preliminary work from our laboratory reported significant differences in the E prime velocity during different phases of the cardiac cycle. Above in panel A, the DTI waveform was recorded at the lateral annulus during normal respiration, and as you can see, there's a respirometer to follow just above the EKG signal. Although the quality of the DTI waveforms, as you can see, are fairly reasonable, you can appreciate the significant changes that occurred in the E prime velocity during inspiration. The E prime velocity decreased from 12 to 8 centimeters towards end inspiration, demonstrating over a 30% change in the E prime velocity. And we found that this doesn't happen as much with the septal E prime velocity, but occurs much more often with the lateral E prime velocity. And this change in respiration can occur up to 70% of difference between apnea and end inspiration. Now, below in panel B, the DTI waveforms were recorded in the same patient at end apnea. The waveforms are uniform with little or no variation. The peak E prime velocity from 4 different cardiac cycles measured 7 centimeters per second. Now, I will say it is definitely recommended that not only DTI, but all Doppler tracings be obtained during quiet respiration or apnea to reduce variation. Now, I want to point out one caveat, which is color DTI. Do not use color DTI for the E to E prime ratio. And the reason for is that color DTI displays the mean, not the maximum instantaneous velocities. Therefore, the velocities across the board are lower, which was demonstrated by McCulloch and colleagues and reported in the American Society of Echocardiography Journal in 2006. Validation of the E to E prime ratio for the estimation of filling pressures was performed with pulse wave DTI, not color DTI. So, importantly, the new systems are equipped with color DTI. However, do not use the E prime velocity and when estimating the E to E prime ratio, as you will significantly overestimate the E to E prime ratio. This next slide discusses the estimation of filling pressures and the E to E prime ratio in patients with atrial fibrillation. Again, another disease that has little validation with filling pressures and E to E prime ratio, yet one of the most commonly sustained arrhythmias encountered in clinical practice in the echo lab. So, can we estimate LV filling pressures in patients with atrial fibrillation? I will say that there's one study that was published by Dr. Son and colleagues who measured tau, time constant to relaxation, in 27 patients with non-rheumatic atrial fibrillation. DTI was measured at the septal annulus and tau, like the other studies used with validation. The tau greater than 50 milliseconds was considered abnormal. Left ventricular pressure at end diastole and tau were measured in 12 cardiac cycles, and the mitral inflow measurement was measured in another 12 cardiac cycles, and the mean values for the left ventricular pressure and tau in these 24 cardiac cycles were used to estimate tau. What they found that prolonged tau greater than 50 milliseconds could be predicted by an E prime velocity less than 8 centimeters per second with reasonable accuracy. And as you can see to the top right, the linear regression equation demonstrates that the E to E prime ratio showed a positive correlation with left ventricular filling pressures, and a ratio greater than 11 could predict elevated end diastolic pressure. So the answer is yes, we can estimate filling pressures with the use of the E to E prime ratio, but in my opinion, further cross-validation is needed. So can we estimate diastolic function and suboptimal image quality? As you can see here, there's clearly no information about left ventricular function in this patient. In fact, all we see is really a silhouette of the left ventricle and the left atrium. But what's important is that Doppler is one of the least image quality dependent techniques used. And to our advantage in a patient like this, I would attempt to assess diastolic function. And also, if you look closely, you see that the annular level is well defined, at which we would be able to estimate the E prime and E to E prime ratio. So look what I teased out in this example. You see that the mitral E wave is about as good as it gets, and you see that there's nice crisp peaks with nice clear deceleration time. The peaks are well defined, and the mitral inflow is easily measured. I then shift the sample volume slightly towards the annulus. I drop the filter slightly, and you see we get a nice measurement of the A wave duration. And if we move further on to the Doppler tissue imaging, and you see that the E prime in this example is just 8 centimeters per second, and you see that the E to E prime ratio equals 10. So no evidence that there's elevated filling pressures thus far in this patient. We move over to the lateral side, and we see that the E to E prime ratio, the E wave velocity is now 11, because as we know, the septal E prime velocities are slightly lower than the lateral E prime velocities, and that can be for several reasons. I think one main reason is that the septal annulus is tied into the RV. There's a lot of interaction occurring there, and where the RV free wall is exactly what it is a free wall. So there is a lot more motion and more kinesis occurring in that basolateral wall, also as it is one of the areas that's least affected by ischemia. So you see that the E to A ratio, E prime to A prime ratio is normal, and the E prime velocities are near normal also. Let's now look at the pulmonary veins. Amazingly, I was able to tease out the pulmonary vein Doppler in this example, and clearly we can see that the S is greater than the D wave. The duration can be clearly measured of the A wave, and the velocity reversal can be clearly measured, all of which check in normal. And lastly, color M mode, even attempt to do that because color M mode has an application of color Doppler in it. Therefore, you see that the color M mode slope in this example is extremely normal. So if you do have a patient with suboptimal image quality, do not hesitate to assess diastolic function. Okay, let's now head towards the last leg of this presentation and discuss the case studies. This first case is from a 60-year-old male with acute onset of dyspnea, tachycardia with an EF of 25 to 30%. You see that there is multiple wall motion abnormalities with a PASP, or pulmonary artery systolic pressure, equaling 50 millimeters of mercury. There is no significant valvular disease with moderate left atrial enlargement. So are the filling pressures elevated? So as we can see here, the sample volume is placed at the mitral valve tips to the top left. We see that we have what looks like could be possibly a ratio that's increased, a rapid deceleration time. So you see that the EDA ratio is 2. We see that the deceleration time is 125. We then look to the right. We tried to measure the A wave duration by repositioning the sample volume towards the annulus, but because of the fusion of the E and A wave, we were unable to measure the A dir, and that's a product of the tachycardia. So then you look to the bottom here, bottom left, and we see that we have a pretty adequate Valsalva that was performed, and we see that Valsalva reduces the E wave, increases the deceleration time, which was not measured, but you can clearly see that it's increased, and which increased also the A wave. And then off to the right, we see that the pulmonary vein D is greater than S, and in some examples, you just can't see the A wave reversal. So there's no A wave reversal measurement. Although there's a faint signal, it's just not good enough to measure. So off to the right, you see that the E prime velocity was measured equaling just 5.5 centimeters per second. So the E to E prime ratio from the septum equals 21. Down below, the color M mode velocity propagation equals 40 centimeters per second. And then you see off to the right, we measured, because of wall motion abnormalities, we measured the lateral E to E prime ratio, and you see that equals just 12 centimeters, 12. So the average E to E prime ratio equals 17. So this patient has stage 3 reversible restrictive. Why? Because we have an elevated E to A ratio. We have a rapid deceleration time less than 140. We see that there are significant changes into E to A ratio with Valsalva. We see that the S to D ratio is reversed, and also we see that the velocity propagation is less than 45 or 50 centimeters per second. And also an average E to E prime ratio in this patient is 17. So this patient nicely fits the scheme that's been proposed by Redfield and colleagues. This next patient is a 54-year-old female with a history of hypertension, recent MI with two-vessel disease. She's status post-CABG with clear LV apical dysfunction. She has LVH, mild LAE, mild mitral regurgitation, and a pulmonary artery systolic pressure of 39 millimeters of mercury. You see to the top left, the mitral inflow looks normal with the mitral E to A ratio of 1.3. The E wave deceleration time equals 222 milliseconds. To the top right, Valsalva was performed, which showed that the E wave reduced and deceleration time increased along with A wave increase. To the bottom left, you see that the sample volume is repositioned towards the annulus, and the A wave duration measures 120 milliseconds on average. And then off to the right, you see that the pulmonary vein D wave is greater than the S wave, and the pulmonary vein A duration equals 166 milliseconds. Here are the corresponding tissue Doppler and color M mode signals in the same patient, and you see that the lateral E prime velocities in the above panel are measured at are actually averaged because of wall motion abnormalities with the septal E prime velocities, which equal 4, which give us an E to E prime ratio of 26. Then off to the right, you see the color M mode propagation equals just 33 centimeters per second. So this patient has pseudonormalization, and as you can see, in the top panel, the mitral inflow pattern checks in, looks normal. Everything is normal. Deceleration time is greater than 140. The ratio is normal. But look just below, you see that the E wave decreases and the E wave decreases, deceleration time increases, and A wave increases in that example. And you see that the S is less than the D wave, and the A wave duration is significantly greater than the mitral A wave duration. The velocity propagation is less than 50, and the E to E prime ratio is 26. So I just showed you two examples that have excellent correlation or have excellent concordance with what has been published in the literature demonstrating the different variables used for the assessment of diastolic dysfunction. The next example is from a 17-year-old male that has dyspnea, edema. There's no significant valvular disease. There's mild mitral regurgitation, mild left atrial enlargement with a pulmonary pressure of 40 millimeters of mercury. And you can't see it that well, but This patient has a very dynamic ejection fraction. The question is the dyspnea directly related to the patient's filling pressures and ventricular function? As you can see here, the sample volume is carefully placed at the mitral leaflet tips, and the mitral E to A ratio equals 0.7. The E deceleration time equals 349 milliseconds. Off to the right, the sample volume is repositioned towards the annulus, and the mitral A-wave duration equals 137 milliseconds. To the bottom left, you see that the lateral DTI E prime velocity equals 6 centimeters per second, and the E to E prime ratio is just 8. To the right, pulmonary veins, S-wave is much greater than the D wave, and the pulmonary vein A-wave duration equals 140 milliseconds. So this patient has stage 1 impaired relaxation, and for obvious reasons, the mitral EDA ratio is less than 1 or less than 0.75. You see that the deceleration time is increased. In patients in our laboratory, typically we do not perform Valsalva maneuver in patients that have a delayed relaxation filling pattern, as we really don't see a lot of change in the E wave velocity. Therefore, it is not routinely measured. Below that, you see that the pulmonary vein S is greater than D, and the A wave duration, although up top normal with the velocity at 34 centimeters per second, the duration does not exceed the mitral A wave duration. And also in these patients, typically we do not measure the color M mode propagation. And you see that the E to E prime ratio equals 8. So given the three measurements, 3 out of 3 tells us that this is a stage 1 impaired relaxation example. That would be what was reported in this patient. This next example is from a 36-year-old male who was extremely obese with a BSA of 2.51 meters squared. This patient has obstructive sleep apnea with a highly elevated pulmonary pressure, a raw number PA pressure at 52 millimeters of mercury. The patient has mild to moderate mitral regurgitation, moderate LAE. This patient's EF is 35 to 40%. This patient's symptoms are that of chest pain, palpitations, and dyspnea on exertion. As you can see, to the top left, we have a mitral E to A ratio of 2.6. We see the deceleration time is rapid at 138 milliseconds. And we see that the A wave is very low and truncated. We then look to the right as we reposition the sample volume to measure the A duration. Our A duration in this example is 140 milliseconds. To the bottom left, the color M mode velocity propagation equals 38 centimeters per second. And you see down below here, there's little change with Valsalva maneuver in this patient. And here are the corresponding waveforms from the pulmonary veins and the tissue Doppler. And you see that the mitral A wave duration is significantly less than the pulmonary vein A wave duration. You see that the S to D ratio in the pulmonary veins is reversed, D being very dominant in this example. And then you see below here the septal DTI E prime measures 5 centimeters per second, and the E to E prime ratio is 16. And just to the right, you see that because of wall motion abnormalities, we measured the lateral DTI, and we see that the E prime is 6 with an E to E prime ratio of 13. So this patient has fixed restrictive or irreversible restrictive filling. And this is based on the measurements showing that we have very restricted type mitral restrictive filling for the mitral inflow. We see that there is little or no change in the E to A ratio with Valsalva. The S to D ratio is reversed, and we have significant atrial reversal duration compared to the mitral A wave duration. And we also see that the velocity propagation is decreased, and the E to E prime ratio is 15. This next example is from an 82-year-old female with a history of hypertensive heart disease, history of congestive heart failure, has multiple wall motion abnormalities, has moderate to severe LAE. Her pulmonary pressures are 48 millimeters of mercury. Her EF is 35 to 40%. She has mild MR, AS, and AI, and she has pretty significant mitral annular calcification. As you can see here, we have the transmitral profile to the top left, and you see that the mitral E to A ratio is 1.7, and the deceleration time is 191 milliseconds. Then off to the right, we see that the sample volume is repositioned to the annular level, and that kind of corresponds as you see the degree of MR begin to increase also. That tells you that you're getting to the right location when measuring the A duration. And in this example, the duration measures 122 milliseconds. Down to the bottom left, you see the Valsalva was performed, which reduces the E wave, increases the deceleration time along with the A wave. And then to the right, you see that the pulmonary veins D wave is much greater than the S wave. However, another case where we're unable to measure the pulmonary vein A wave duration and or reversal velocity. So I just want to say caution, there's severe MAC in this example, as noted on the previous slide. And as you can see here to the top right, you see the sample volume is positioned at the MAC, at the annulus, and the E prime velocity is just 5 centimeters per second. But look, just by repositioning the sample volume below the MAC, we then double the E prime velocity at 10 centimeters per second. That is a 100% increase in the E prime velocity, which is subtle movements of the sample volume positioning. So in this example, we would not use the tissue Doppler because it's unclear which E prime to use. So this patient has stage 2 pseudonormalization. As you can see from the top example of the mitral inflow, it appears to be normal, but with Valsalva there was a significant reduction in the E prime, in the E wave velocity, and the deceleration time increased along with a slight increase in the A wave. Then below there, you can see where the pulmonary vein D wave is dominant, where D is much greater than S. Although the pulmonary vein A wave reversal velocity and duration could not be measured, we can see that we're not going to use the tissue Doppler in this example, and the color MO was not measured. But 3 out of 5 have concordant data showing that this patient indeed has elevated filling pressures. This next example is a 91-year-old male who was a tennis player, very active, with a recent MI, unfortunately, that has new dyspnea with no significant valve disease. His PASP is 35 millimeters of mercury, which could be normal in a patient of his age. Apical wall motion abnormalities are evident here, and we see that the EF is mildly reduced. So the mitral inflow shows an EDA ratio, in the top left here, shows an EDA ratio of 0.5 with an E deceleration time of 288 milliseconds. This is what we would expect to see potentially in a patient of this age. We see that over to the right, the mitral A wave duration equals 156 milliseconds. And just below to the left, we see that the pulmonary vein, although slightly faint, it could be recorded, and the S wave is greater than the D wave. However, we could not measure the pulmonary vein A wave duration, and the reversal velocity is actually normal. Off to the right, you see the tissue Doppler obtained from the lateral and the septal annulus, and you see that there is a marked reduction in the tissue Doppler with an average septal to lateral DTI E prime of just 3 centimeters per second. So in this example, the ED prime ratio equals 24. So this patient has delayed relaxation, impaired relaxation. And you see that the top example checks in that the E wave's low, the deceleration time is increased, the A wave is up. We did not measure the color M mode in this example. But if you look below, the S to D ratio looks normal. In fact, the D wave is very low, indicating that the filling pressures are more than likely normal. And we did not measure color M mode, but clearly there's a discrepancy in this example using the tissue Doppler. The ED prime ratio was significantly elevated. But we have 3 out of 5 that tell us, along with the PA pressure, that this patient does not have elevated filling pressures and indeed is an impaired relaxation filling pattern. This next example is of a 60-year-old male with hypertension, CAD, has apical wall motion abnormalities with an EF of 55 to 60%. No estimated PSP was obtained in this patient. However, this patient has moderate left atrial enlargement. As you can see here, in the top left, the mitral EDA ratio is 1.3. The E deceleration time is 232 milliseconds. To the right, you see that Valsalva was performed correctly, and there was a significant reduction in the E wave velocity and the A wave increase along with deceleration time. Down below, you'll see that the septal E prime velocity equals 3 centimeters per second, which is significantly abnormal, and the ED prime ratio is astronomically high at 42. Off to the right, the lateral E prime velocity is just 7 centimeters per second, and the average E to E prime ratio equals 29. In addition, here are the pulmonary vein recordings, and showing that the pulmonary vein S wave is greater than the D wave. The pulmonary vein A duration equals 158, as opposed to the mitral A wave duration, which is 152, so slightly increased. And we see that the atrial reversal velocity is just 27 centimeters per second. So we see that this patient has pseudonormalization. We see that the mitral inflow checks in, the E to A ratio, deceleration time, and A wave, all normal. We see that, however, the Valsalva maneuver unmasked the elevated filling pressures and the underlying relaxation abnormality. But interestingly, we have a discrepancy with the pulmonary veins. We see that the S was greater than the D, the atrial reversal velocity was not increased, and the A duration was not significantly increased. In this patient, color MO was not measured. However, the ED prime ratio equals 29 averaged. So we have 3 out of 5 that show that the patient has indeed elevated filling pressures, and we would not use the pulmonary vein waveforms as part of the assessment of diastolic function in this example. This next example is of a 29-year-old male with chest pain, mild DOE, with a BSA of just 1.2 meters per second. The PASP equals 25 millimeters of mercury with no significant valvular disease. Normal LA size with an EF of 60 to 65% and no wall motion abnormalities. As you can see, the mitral E to A ratio equals 2.9, and the E deceleration time is 126. Off to the right, the D wave is much greater than the S wave, and the pulmonary vein A duration equals 122 milliseconds. To the bottom left, you see that the septal E prime is 15, and the E to E prime ratio equals 7. Over to the right, you see that the lateral E to E prime ratio is 6, and the E prime velocity is 18. This patient has normal diastolic function. Although there is a restrictive filling pattern in the mitral inflow, this is most likely caused, as I mentioned earlier, from vigorous diastolic suction and not driving left atrial pressure that's elevated. You see that in this example, we did not measure the Valsalva maneuver. The pulmonary vein S to D ratio is actually reversed here, and in young patients, we often see that also. That if we have a very tall E wave, the pulmonary vein D wave tends to follow that. So we see that the ratio can be reversed where the D wave is greater than the S wave. However, the pulmonary vein reversal velocity durations are normal. We did not measure the color M mode, but we clearly see that the ED prime ratio is average from both the septum and lateral annulus equals 7 centimeters equals 7. So in this case, looking at the weighted information, just looking at the mitral inflow and the tissue Doppler and the pulmonary veins, we know that this patient does not have elevated filling pressures. This next case is from a 60-year-old male with hypertension, diabetes, and end-stage liver disease. This patient has a chief complaint of dyspnea, has moderate LVH, no significant valve disease, mild to moderate left atrial enlargement, with a pulmonary artery systolic pressure of 48 millimeters of mercury. This patient's EF is 55 to 60%, which is normal. So you see the corresponding waveforms here in the top left of the mitral inflow. You see that the mitral E to A ratio equals 1.1, and the E deceleration time equals 164 milliseconds. Of note that this patient is bradycardic, and there is a waveform that occurs between the E wave, the transmitral E wave, and the transmitral A wave. You see that forward flow during diastasis. That waveform indicates one of two things. One, bradycardia can create that, and secondly, that is observed in patients with advanced hypertensive disease. Off to the right, you see the Valsalva maneuver was performed correctly with a significant reduction in the E and A wave with a significant increase in the deceleration time. You see down below that the mitral A wave duration in this patient measures 144 milliseconds. And off to the right, although difficult to see, it looks like we get a fairly decent representation of the pulmonary veins, but we see that the D wave is obviously larger than the S wave, and the A duration equals 158 milliseconds. Here are the corresponding tissue Doppler waveforms in color M mode, and as you can see, the average EDE prime ratio from both the septum and lateral wall equals 18, and to the right, the color M mode equals 102 centimeters per second. So this patient has stage 2 pseudonormalization. Well, we see that the mitral inflow looks normal. We see that with Valsalva, there is a clear change in the E to A ratio and deceleration time. We know that the pulmonary vein Doppler is also consistent with elevated filling pressures, and the E to E prime ratio is significantly elevated at 18. But you see the color M mode in this example did not work. You see that there is a discrepancy. And I will say that the color M mode does not work well in patients with normal LV systolic function, as this patient has. So here's another case of a 60-year-old male with 3-vessel disease, recent MI, has 1+ at mitral regurgitation, has multiple wall motion abnormalities, as you can see, with an EF of 25 to 30%. No estimated right ventricular systolic pressure, with moderate left atrial enlargement. You see here to the top left of the corresponding Doppler tissue waveforms, and you see DTI obtained from both the septum and lateral annulus. We have an average ED prime ratio of 14. Off to the right, we see that we have a mitral E to A ratio of 0.5, E deceleration time of 308 milliseconds. To the bottom left, we have a mitral A wave duration of 119 milliseconds. Now, to the bottom right is the pulmonary vein Doppler tracings, and you see that the S is greater than the D with a very low D wave, but you see that the pulmonary vein A duration is 193 milliseconds, and the atrial reversal velocity is 67 centimeters per second. This patient has stage 1 impaired relaxation. As you can see, the mitral inflow has a very low E to A ratio with an increased deceleration time with no indication that the filling pressures are elevated. We did not measure the Valsalva in this patient. However, if you look at the pulmonary veins, you see that there's a very prominent S wave with a very low D wave with a very, very prolonged atrial reversal velocity duration along with a very high atrial reversal velocity. What I think is occurring in this patient is that the mean left atrial pressure may not be elevated. However, there is a marked increase in the end LV diastolic pressure, and I would guess that the end diastolic pressure in this patient is significantly elevated. You see just below there that we did not measure the color M mode and that the E to E prime ratio is 14. Final thoughts. The assessment of diastolic function requires a detailed understanding of patient history, heart structure, and physiology. Estimation of filling pressures can help the clinician tailor therapy. No single measurement can be used to diagnose diastolic dysfunction. Diastolic function requires a stepwise approach, and most importantly, are the pulmonary pressures elevated? Is there left atrial enlargement? If not, more than likely the PCWP, with exception, is normal. I thank you for your attention.